This is Dr. Sanjay Prasad Gupta, a gynecologist. Today's topic of discussion is birth defect. We all want a healthy baby, devoid of any birth defects or congenital anomalies. So, we should do everything to diagnose, to prevent, and to terminate, if needed, a anomalous fetus. Because a anomalous fetus is a huge burden to the family, to the society, and to the nation as a whole. The risk of congenital anomalies more or less 3 to 4%. Sometimes it can increase up to 9% in some high risk. Now the types of birth defects. There are mainly three types of birth defects. Type 1 is malformation. This occurs due to the intrinsic defects in the fetus, such as it may be chromosomal or genetic. Type 2 is deformation. Here the birth defects occurs due to the outside problem of the fetus, such as oligohydramnios, which can cause flexor contracture deformities, pulmonary hypoplasia, or deformed foot. Amniotic band syndrome also can cause deformation. Type 3 is disruption. This occurs due to the loss of tissue. Example is some type of trauma, some type of teratogen exposure such as medication, chemicals, mutagens such as the radiations, X-ray, or some types of metabolic conditions such as the diabetes, which causes hyperglycemia, phenylketonuria. Those also acts as teratogens, and infectious insults also cause disruption type of fetal abnormalities. Prevention of birth defects. The most important preventive step is all mothers who is trying to conceive, they should be given preconceptional at least 6 to 12 weeks before folic acid supplementation, especially if the mother is diabetic and or the mother is giving history of neural tube defects before, or mother is on anti-epileptic medications. Next, we should go for ethnic screening also for single gene defects, such as we are highly prevalent for thalassemia and sickle cell disease. So every mother should go for hemoglobin electrophoresis, that is HPLC, before conception. And if they are found to be positive, then her partners are also supposed to be tested. If both of them are carrier, then only there is chance, 25% chance of thalassemia major. In that case, after the conception at 11 to 14 weeks, we can go for chorionic villus sampling for free prenatal diagnosis, or we can also go for pre-implantation genetic diagnosis, or we can also go for healthy sperm or ovum donation, and lastly we can go for the adoption also. Next, our society is highly prevalent for diabetes also, and hyperglycemia also acts as a teratogen. So diabetic screening is also recommended. Next, we should avoid teratogenic drugs, alcohol, substance abuse, excess of caffeine. Next, we should get the proper family history. If there is any history of birth defect child in the family, or if the parent is undergoing recurrent abortion, if there is giving history of stillbirth, if there is previous abnormal baby, then we should go for the genetic diagnosis of the baby to prevent further recurrence. If at the same time, if there is any abnormal baby mentally, or autistic behavior, or if there is history of mental retardation child in the family, then we should go for the genetic diagnosis to prevent the recurrence of the same disease in the family. Then if the mother is on any medication, so we should see in which period the medication has been taken. Up to the last menstrual period, that is 2 weeks after the fertilization, there the drugs or the fetus follows the all or none phenomena. That is, if the fetus is affected by the drug, then it will be aborted, and if it is not affected, then it will continues as a healthy fetus. So mothers should be advised to stop any medication if they misses a period, and the maximum chance of teratogenesis is 2 to 2 to 8 weeks of embryo, and even after that some system goes for the development, so they are vulnerable for teratogenic defects. And if the mother is on any anti-epileptic medication, then we should go for lamotrigine or levotiracetam, which has got favorable side effects. Now, the causes of birth defects. Birth defects may be chromosomal. The numerical chromosomal abnormalities may be aneuploidy, such as monosomy or trisomy, or it may be polyploidy, or there may be structural rearrangements also of the chromosome, such as the deletions, duplications, insertion, isochromosome, or translocations. Now, there may be single gene defect as well, which may be autosomal dominant, autosomal recessive, X-linked recessive. Sometimes it could be X-linked dominant and Y-linked also. There may be trinucleotide expansion repeats. There may be uniparental disomy. There may be genetic imprinting type of abnormalities. There may be mitochondrial inheritance also. Now, the third cause is polygenic. Polygenic means multifactorial. Here, multiple genes are affected, and the variants can be considered as the normal polymorphic variants, but if they are together and if they secondarily hit by the environment, then it causes the disease. So, it may be not that much severe, and if the adverse environment is not present, then the disease may not be manifested. And the last one, the last cause is the teratogen exposure, that is purely environmental. Now, how to diagnose birth? Now, how to diagnose birth defects? After the conception in the first trimester, every mother should be offered first trimester trisomy screening in the form of double marker, that is serum analytes of Papa and beta HCG and NT scan. And the first trimester soft markers for Down syndrome are nasal bone, nuchal translucency, TR, and blood flow through the ductus venosus. And accordingly, we classify in terms of low risk, where no further test is indicated, intermediate risk, that is between 1 by 100 to 1 by 1000. In that case, better to go for non-invasive test, which is done from the cell-free fetal DNA from the maternal serum, and shotgun sequencing or targeted gene sequencing, we can identify the particular trisomy. But if it is in the high risk group, that is above 1 by 100, then in that case we should go for the invasive testing in the form of chorionic villus sampling and karyotyping of the tissue. When the mother goes into second trimester, then also we can go for the aneuploidy screening and neural tube defects screening in the form of serum analytes of beta HCG, maternal serum alpha fetoprotein, estriol, and inhibin A. And accordingly, if it is in the high risk zone, then we should go for the invasive testing through amniocentesis. Now, the final anomalous scan can be done at 20 to 22 weeks when a thorough anatomical survey of the whole system and every organ of the fetus is inspected. And if there is any major defect is found, then invasive testing through amniocentesis has to be done. And in this case, simple karyotype of the tissue will not do, because simple karyotype will not diagnose the microstructural rearrangements such as microduplications and microdeletions. In that case, we have to go for the chromosomal microarray to diagnose the micro deletions and duplications of the chromosome. But if there are single soft marker present in the USG that needs only follow-up, such as choroid plexus cyst or pileectasis or mild ventriculomegaly, in those cases only follow-up needed. But if more than one soft markers are present, or if heavy or major structural defect is seen, then we should diagnose, and if needed, it has to be terminated. And some cases also we should go for the fetal echocardiography. Suppose if mother is suffering from diabetes, if the pregnancy is following in vitro fertilization, or if the mother is on anti-epileptic drugs, or if there is previous history of congenital heart defect, or if the mother is having heart defect, or if the fetus has been exposed to some drugs which is teratogene to the heart, in those cases we should go for the fetal echocardiography to rule out cardiac defects. So, and even if suppose we cannot terminate the pregnancy, then before conception or before implantation, the embryo can be diagnosed for the birth defects through pre-implantation genetic diagnosis. The biopsy can be done from the polar bodies, from the blastomeres, from the trophoectoderm, or lastly, and the newer form is cell-free embryonic DNA from the culture media. So through those things we can diagnose the defect, and if it is abnormal, we just don't implant the embryo. So this is the way we just diagnose, and if needed, we terminate the pregnancy as early as possible. In addition, I want to add two more things. One is hyperthermia should also be avoided, and if required, Calpol or paracetamol has to be taken. And regarding karyotyping, it needs cell tissue culture. So it requires more time, and it takes 2 to 3 weeks time for the reports to come. And if tissue culture is failed, in that case common chromosomal fish can be done, and through that technique the results are available in 48 hours, but only common chromosomal disorders can be identified. And lastly, CMA technology also does not require cell culture, and the results are available in 7 to 10 days. And for the single gene defects or known genetic disorder, quantitative fluorescent PCR can also be done, where the reports are available in short. That's all for today. Thanks for watching, and do subscribe my channel for similar type of video in future. Thank you very much. Jai Hind.